Okay. Let's see, what do I want? Oh, I want to get that code. Med code. Okay. Okay. How's that? The light professional? Well, I gotta pin it first. Pin video, okay. How's that look? Come on, guys. Oh, let me get some feedback. Oh, good. Okay. Oh, good. Okay. Hi, Dr. Sevilla. Can you hear me okay? Can anybody hear me okay? Any of the panelists can hear me? Hello, I need your feedback. Can you hear me?
Yes, I hear you, John.
Okay, who's Manuel? How you doing?
All good, John. And you? How is all going?
You know, I recognize your voice. I didn't even see your face.
How is all going, John?
Let me take myself off that. I got my unpinned video. Okay. So you're home?
Yes, yes, I am home today.
Oh, okay. Okay. Okay, I'm just setting up now. Okay. Excuse me for a second. I'm just gonna hold on. Hello, Dr. Abraham. Can you hear me? Oh, there you are. Okay, you got it. It's okay.
Hello.
Yeah, it's okay?
Yeah.
Yeah. Maybe it's my volume. Hello, can you hear me okay? Hello? Hello? Testing, 1, 2. Can someone talk?
Hello, sir.
Okay, you can hear me? Okay, how you
Hello,
doing?
sir.
Yeah, how you doing, Hanga?
Yeah,
You can hear me okay?
I'm fine. I'm seeing you. Yeah, I'm okay.
Okay, yeah, don't put your picture on. That way you save bandwidth. You know that, right?
Yeah.
Okay. Okay, hold on, Dr. Sabir, just 1 second. 1 second.
Sure.
Oh. Okay, you ready to start?
Am I starting?
Yeah, are you ready?
Yeah, I'm ready, of course.
Okay, 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. It's Dr. John Bennett, broadcasting for Neurosurgery TV. We have another daily dose of neurosurgery education. And we have Dr. Ibrahim Sabeya from Jordan, who does a regular webcast Mondays and Wednesdays for the Jordan Grand Rounds, Neurosurgery Grand Rounds. Anyways, I'll just turn right over to Dr. Sabeya and welcome, and it's all yours, Dr. Sabeya.
Thank you very much indeed, and hello to everybody. If anybody is joining us for the first time, my name is Ibrahim Sabeya. I am a neurosurgeon from Amman, Jordan. And we are transmitting live from the Farah Medical Campus here in Amman, Jordan. The topic for today will be aneurysmal bone cyst. The abbreviation is ABC, and I will concentrate on the aneurysmal bone cyst of the skull base. But generally, if you look at the classification of the WHO for the tumors of the maxillofacial region, classification into benign and malignant, and then you look here, you will find that aneurysmal bone cyst is under the benign tumors. So it is not a cyst, it is a tumor. And this is by the WHO definition. It's a benign neoplasm of bone composed of blood-filled spaces separated by septation containing fibroblast, osteoclastic giant cells, and reactive woven bone, as you can see here. So ABC, or aneurysmal bone cyst, is a misnomer. It's a wrong terminology. It is not a cyst. It is not an aneurysm. It is a neoplasm. It is a tumor. And it constitutes 1% of all primary bone tumors, usually young age, 5 to 20. Males and females are equal in incidence. And this disease or tumors can affect any bone in the body, and it is very, very rare in the skull base. First time it was described was back in 1942 by Jeff and Lichtenstein, and they said this: when they opened the thin wall, they were confronted with a large hole containing fluid blood. And for anybody who's dealing with these aneurysmal bone cysts, that's what you feel. You feel that you are going into a big chamber with lots of bleeding. These aneurysmal bone cysts could be primary, could be secondary. Primary meaning de novo, secondary meaning that the aneurysmal bone cyst is associated with or coming or arising on top of another tumor. But the majority are primary, and most of the primary you would get some history of trauma. Same theory that is applied in meningiomas. Those who operate on meningiomas, once you do the shaving, you would find some scar on the scalp. So it's either primary or secondary. Whether it is a primary or secondary, something happens, then there is subaosteal or interosseous hematoma, and this would create a high flow AV shunting like this. And once that happens, the bone will erode, the cortex will get thin, more bleeding, more cavities, bone, of course, it is thin, it will collapse, and then you start soft tissue invasion. So we are dealing with a tumor, not a cyst. As I said, the primary aneurysmal bone cysts are the majority, and usually there's history of trauma, while the secondary ABC is the minority, 30%, and there is a lesion. So you look at the images, you find the lesion, and then this develops on top of it. So usually it develops on top of tumors, bony tumors, giant cell tumor, chondroblastoma, osteogenic sarcoma, hemangioma, and sometimes onychocytosis, and so on and so forth. Fibrous dysplasia, metastasis, or radiation. For the cases developing on top of fibrous dysplasia, these are the applications. So it is fibrous dysplasia with aneurysmal bone cysts. I would refer to this paper, and I'm really happy to put that for your attention. It is from Lebanon back in 1998. This war-stricken country is great, still great with his neurosurgeons. And the very senior surgeon, Fuad Haddad, late Dr. Fuad Haddad, he actually introduced neurosurgery to the Middle East back in the 50s. And fortunately, his son, George Haddad, is another neurosurgeon. And they found that this case of this lesion was fibrous dysplasia and aneurysmal bone cyst developed on top. This from China, again, this was aneurysmal bone cyst developing on top of fibrous dysplasia. From Taiwan, fibrous dysplasia developing into ABC. Fibrous dysplasia from South Korea developing into ABC. So this is secondary aneurysmal bone cyst. Other tumors like osteoblastoma also can be associated with aneurysmal bone cyst. So this started as osteoblastoma, but then tend to have aneurysmal bone cyst with it. Another case from Japan, aneurysmal bone cyst on top of osteoblastoma. It can develop on top of chondroblastoma, this paper from USA, 2010. Another case of chondroblastoma. In this case, it developed on top of leukemia, leukemic infiltrate. What is the radiology of these cases? This paper from Taiwan describing the computer tomography and magnetic resonance imaging. This is how it looks on the skull X-ray, punched out, bony defect like this. And the CT shows the same. So you are talking about a lytic lesion with ballooning of the bone. There is eggshell cortical bone on top, and there is heterogeneous appearance on T1 and T2, like here. So we are talking about blood-filled sponge or bubbly appearance. And one characteristic of these ABC is the fluid levels, and I will show you that. And it is not peculiar to ABC, but once you see it, you think of ABC with other possible differential diagnoses. So here you can see the fluid level. So fluid level is not pathognomonic of ABC. It can happen in other tumors. So this was a giant cell granuloma. This was fibrous dysplasia. This was esthesioneuroblastoma, chondromyxoid fibroma. And this patient is a patient of mine who had thalassemia B, and she had this kind of cystic lesion with multiple levels, chondrosarcoma with multiple fluid level, and even allergic fungal sinusitis can give you the same appearance. Angiogram is mandatory, and you need to see the case of skull base, where is the relationship of this lesion with the carotid, whether it is compressing it, invading it, and so on. You also would need the angiogram to see the feeding artery and then you can maybe embolize it. In this case of skull base ABC with the embolization, with the angiogram showing the feeder to be from the middle meningeal artery. So what's the location of these ABCs? As I said, it can affect any bone in the body. Most of the time, it affects long bones and pelvis. So this is a paper from Boston, and in the Journal of Clinical Oncology back in 2006, they reported 150 patients with the ABC. But look, there's nothing here of any skull lesion, all in the long bones and in the pelvis. So these are the common sites, the long bones, femur, humerus, pelvis, so on. The humerus, you can see the cavity and the side of the bone, femur, humerus again, tibia. And the skull, it can affect any bones, of course, but it has predilection to the frontal and the occipital region. So this is the frontal, paper from India, 2010, frontal bone aneurysmal bone cyst. Look at the operative specimen. And the temporal, it can also occur, and this paper from USA, this tumor in the temporal area. Another paper from United States in the temporal bone, and it was presented with hemifacial paralysis because it destroyed the bone, it destroyed the middle ear and the inner ear. This paper from Nepal, 2013, with this temporal bone cyst. From Canada, temporal bone ABC. We mentioned that from Nepal already. And this paper, the same thing here from the temporal bone, presenting with hemifacial paralysis. Skull base, and this was reported from Saudi Arabia, 1999, 3 cases. Another case from India, affecting the temporal bone. Can affect the occipital bone, and this particular ABC involved the clivus and C1, C2, as you can see here. And from Salt Lake City, another occipital ABC. From Taiwan, this occipital ABC tumor. From Germany, occipital. From Iran, and this is Iran Journal of Radiology, and this is involving the jugular foramen. So the tumor is going into the jugular foramen. A very interesting paper by Atul Goel from India of this ABC in the occipital area and the post-operative cerebellar herniation. Same thing here, the one from Iran. And it can affect, of course, the craniocervical junction. It can affect the orbit. In this paper from South Korea, the tumor is involved in the orbit, as you can see. Another paper from India, tumor is involved in the orbit. From USA, published World Neurosurgery recently, sphenoorbital tumor. It can affect the nasal cavity. Paper from Turkey, you can see the nasal cavity is totally destroyed. Another paper affecting the nasal cavity from Germany, involving the paranasal sinuses. You can see this picture from Portland, USA. Another case of paranasal sinuses from Iran. Sphenoid bone can be selectively chosen for this selective type of ABCs. Another paper from Turkey, the tumor is involving the ethmoids. But still, the skull base in general is very rare for this kind of tumors. Another paper also from Spain with this ethmoid involved, from British Journal of Radiology, from India, this giant ethmoid bone, aneurysmal bone cyst, paranasal sinuses, sphenoid bone from France, sphenoid bone from Turkey, and this is the unusual site, completely intradural. There's no connection with the bone, seems that it slipped the bone and just went inside and to present like intraparenchymal tumor. Paper from India by Sarah Schneer, a friend of mine, and this paper from USA where it is in the cerebral-pontine angle. Another intradural lesion from USA. Further intradural lesion from India. Or it can affect the spine, 15% in the spine. As I said, the majority are in the long bones, 15% in the spine, and very few in the skull base. And in the spine, like the lumbar and the cervical area. Examples of these lesions affecting here. This is odontoid, this is atlantooccipital, the C1-C2 joint is destroyed here. This is lumbar. So what's the management of these cases? People think that these are silly pathologies and it's easy to deal with. And I will show you that it is very, very difficult to deal with. And I say it is not as easy as ABC. And I quoted this from this paper from London, from Charing Cross and Royal London Hospital parts. Pediatric aneurysmal bone cysts are not as easy as ABC. Why is that? Because we are dealing with the young generation, young age of patients. The accessibility is usually very difficult, especially in the skull base. It is very vascular, so you may face severe blood loss. You cannot take biopsy. And look at this frightening fact that there is a high rate of recurrence. So it is not as easy as ABC. It is very difficult and highly challenging. Surgery is the mainstay, and your aim is to remove the lesion. So most of these tumors are treated by surgery, whether microscopic surgery or endoscopic surgery, and your aim is total resection. As in every surgery, your aim is total resection whenever possible and applicable. There's no biopsy, there's no place for biopsy here, or at least you need to be extremely careful because you may face strain, very severe bleeding. So you can do kind of curettage and bone graft. You can use high-speed drill to shape the bone. You can use electrocautery to seal blood vessels. But all these can be used in the long bones, but not in the skull. Endoscopy, as I said, is the future of neurosurgery. And there are some papers on the transendoscopic surgery of fibrous dysplasia associated aneurysmal bone cyst here from the maxillary sinus. You can see the endoscopy did a great job here. Another tumor also affecting the midline, and this is the post-operative by endoscope from Italy, and Italy is one of the leading countries in the neurosurgical endoscopy. Same thing here from Turkey, endoscopic removal. What about embolization? You can use embolization as preoperative, or you can use it as a sole treatment. And the idea is, if you want to operate, you would decrease the bleeding, but sometimes, as I said, you need to use it as curative or as palliative. This paper, selective arterial embolization of 60 aneurysmal bone cysts using N2-butyl cyanoacrylate, and the conclusion was arterial embolization may be the treatment of choice for these aneurysmal bone cysts. Embolization is less invasive, lower cost, simpler procedure than surgery, and easily repeatable. This paper from Italy. This is embolization in the spine, selective spinal embolization, cervical embolization, but few papers on the embolization of skull base aneurysmal bone cysts. Again, this is embolization, and this is the result of embolization, where you can see sclerosis starting. Paper from Japan, paper from Italy. You can see the embolization effect. And here, how effective is embolization? It is, as you can see, very effective. But it has to be done by the experts. What about this mode of treatment, which is the injection of sclerotherapy material? What are the materials that can be injected? You used to inject alcohol. This is very serious if you want to use it in the brain and the skull base. Calcitonin has been used extensively in the long bones, methylprednisolone, calcitonin, and prednisolone together. So these are the injectable materials. In this case, use the alcohol, and you can see the result here. Bisphosphonates. This is before treatment, as you can see, and this is 3 months after treatment. So before treatment, 3 months after treatment using bisphosphonates. Again, from Tunisia, from late Dr. Khalidi, he used calcitonin, and this is before, and this is 20 months after. Needed repeated injections. Intravaginal injection of calcitonin. You can see the sclerotherapy effect of the treatment. And most recently, they have been using bone marrow as a material to inject concentrated bone marrow. So this is one of their cases before 4 months and 18 months. Very good results. What about radiotherapy? It has a place. It has a place for the recurrent cases, for the progressive cases, for the inoperable cases. I'm losing my voice because I'm fasting, so my mouth is dry. So radiotherapy, and this is some of the publications from the United States, the authors and the use of radiotherapy for aneurysmal bone cysts. From Germany, and the use here of radiotherapy in recurrent aneurysmal bone cysts. From India, this is recurrence after surgery, and this is the effect of radiotherapy. So it's a good effect. And here the use of percutaneous radionuclide ablations percutaneous. This is 2 years after. And this is 1 year after. I'll show you some of my cases, a list of cases of mine. This boy, 12-year-old from Iraq, came with this lesion. As you can see, and it turned out to be aneurysmal bone cyst on top of dysplasia. So we did the surgery. This is post-op. Remind you, this is pre-op. This is post-op. So aneurysmal bone cyst on top of fibrous dysplasia. Second case, which we will go a little bit in details, this 7-year-old male patient from Iraq who presented with right eye proptosis and photophobia. And you see that there's a scar of a trauma here. So it seems that this is a primary tumor, secondary to trauma. And what did we find here in his CT scan is an old fracture of his occiput. So it seems that he sustained the left supraorbital trauma fracture of the occiput, and this was the cause of his aneurysmal bone cyst. So you can see the proptosis, the deviation, very ugly disfigurement. And this is the best way to see the proptosis, looking from above. So you can see the difference. There were restriction of his eye movements in all directions, but he had no pyramidal signs. His imaging showed this extensive orbital paranasal sinuses involvement. You can see the fluid level. You can see that it is extending intracranially, T2. And this is the coronal showing you that the roof of the orbit here is not there, and this region is extending there. Now, whether or not the dura was invaded, it will be remain to be seen during surgery. But look at the invasion of the orbits of the maxillary sinus, of the ethmoid sinuses, and so on. CT scan showing you the destruction and the pacification of the ethmoid and incursion on the orbit. Same thing here. Same. The sinus is obliterated. The roof of the orbit is involved. Ethmoid. And this is coronal view, looking at the displacement. The roof is involved, the medial wall is involved, the ethmoid is involved. You can see the destruction here in the laser wing of the sphenoid and in the roof of the orbit and the ethmoid. Sphenoid is involved, and pteroclinoid is involved here. Look how much the roof of the orbit is gone, destroyed, the bone is destroyed. But you would say, is this real intracranial, or is the dura still preserved, meant to be seen during surgery? Nasal cavity is affected. Frontal sinus is affected, you can see. And this is a 3D showing you that the roof and the median and the floor of the orbit is being involved. Angiogram, you can see that ophthalmic artery is definitely contributing to the blood supply of this aneurysmal bone cyst. And I think we should stop saying aneurysmal bone cyst, we should say aneurysmal bone tumor. So we know that the ophthalmic artery, whether directly or through the anterior and posterior ethmoidal arteries, branches of the ophthalmic are giving the blood supply. This is a major point, because here you may not consider embolization for fear of loss of vision. This is the MRV. But if one sees this picture, what is the differential diagnosis? It's horrendous. Let's see. Because you are dealing here with sinonasal tumors and the paranasal sinuses. And those tumors, they would invade by the route of least resistance. So they go into the nasal cavity, the paranasal sinus, the nasopharynx, lamina fabricia, cribriform plate, and so on. What are the benign sinonasal tumors that should be included in the differential diagnosis of this case? Long list. I'll go through that. Inverted papilloma is the most common benign tumor in the sinonasal area. Epidermoid. This one case of mine, and this has been operated upon and was told that this is a malignant tumor. It looked to us as benign, so we went in, moved it completely through modified Ferguson incision, and this is the cavity, and this is the healing. So it was a benign fibroma. This again, tumor is a benign tumor, osteoblastoma, ameloblastoma, and I have chosen these pictures which look like our case. So that one would be convinced that you have a long list of differential diagnoses to think. You have to make a sort of mental exercise every time you see an MRI. Giant cell tumor, angiofibroma, chondromyxoid fibroma, meningioma, that is sphenoorbital or isolated like this, meningiopericytoma, fibrous dysplasia, as I said, aneurysmal bone cyst like this. All these are benign lesions that should be included in your differential diagnosis. A neurofibroma of V2. As for the malignant sinonasal tumors, again, long list. Some of these are squamous cell carcinoma, and this is the most common malignant tumor in the sinonasal area. One case of mine from Sudan, 34, sinonasal adenocarcinoma. You can see the proptosis here. We went in, took it out, and he did very well. Undifferentiated carcinoma, osteosarcoma, chondrosarcoma, rhabdomyosarcoma, lymphoma, neuroblastoma arising from the olfactory bulbs, metastasis, Ewing sarcoma. So we did a few consultations for this patient. We asked our ophthalmologist, Dr. Ibrahim Sadat, to look at him, and he found that on the right he has vision of just counting fingers. So a young boy with this fading vision is something that breaks your heart and makes you want to help this boy in whatever way you can do. Also, the color vision was affected. Visual fields, however, were full, and fundoscopy showed no papillary edema, but OVCT was also done, shows no thinning of nerve fibers with minimal changes in the ganglion cell on the right side. So diagnosis was right, optic neuropathy and proptosis. And these are the visual fields and the OCT and so on. We do this pre-operative and post-operative. We got the appropriate consent from the patient, and I always say that there is no general, common, universal consent form. Each patient must have his consent form tailored for his own condition. So we actually take a very detailed consent. Before we go through surgery, let me go through some anatomy that we need to know and that we will face during surgery. We'll be operating on the right orbit. So again, the orbit here, the rule of 7 applies: 7 bones, 7 arteries, 7 veins, 7 nerves. So one has to know the exact anatomy of the orbit. And for those neurosurgeons who think the orbit is not their domain, it is the neurosurgical domain, except for the anterior part, for the globe itself. It is for ophthalmologists. And recently, the oculoplastic surgeon can deal with some of the orbital lesions. But orbit is a neurosurgical domain, and anatomy must be mastered by every neurosurgical resident. Because simply you may need to operate on a fracture in this area, so you need to know the anatomy. 7 bones. The major bones that you have to remember is the ethmoid bone, made of the head, the body, and the legs, and the 2 wings, the greater wing, the lesser wing. So it's like a bird, like a body with the wings and legs and so on. And this attached to the medial and lateral pterygoid plates is the ethmoid bone. Again, here you can see the greater wing, the body, the legs, which are the medial and lateral pterygoids, and the palatine bone articulating with it. So this piece of anatomy is very vital, and every neurosurgical resident must know it. Here you apply the maxilla, so you have a full picture. And this is the nasal septum, and you can see the conchae. And if you go deep, then this is the orbit, this is the maxillary sinus, and this is, I'm showing you the infraorbital nerve, which must be preserved in this kind of surgery. which is this one. Coming here on the right side, if you cut the medial canthus ligament, then you can access the medial wall of the orbit. And the medial wall of the orbit is mainly made by the ethmoid, a small piece inside by the ethmoid, and here is the nasal bone. One piece of anatomy that one has to remember is the lacrimal sac and lacrimal duct, nasal lacrimal duct. The two canaliculi, superior and inferior, join together to form the lacrimal sac, which is here, and then you have the nasal lacrimal duct, which is draining into and under the inferior conchae and the inferior meatus. Have also to remember this anatomy here, the tarsal plate, the arrangement of the muscles. The tumor in this case is here and in here. So we now have to know this anatomy very well. Muscles, the canthal ligament, the ethmoidal artery, anterior and posterior. So as I said, once you cut the medial canthal ligament, then you can see the whole of the medial wall, and you can get into the ethmoid, and from there you can go to the sphenoid. Here, major bleed that you may face is from the ethmoidal artery, whether anterior or posterior. Coronary view of the orbit in relation to the maxilla, which is forming the floor of the orbit here. These are the turbinates, conchae and turbinates. Go deeper, then this is, you have gone through the anterior wall and the cavity of the maxillary sinus, are facing the posterior wall of the maxillary sinus. If you open it, you'll be in the pterygopalatine fossa. A must anatomy for the neurosurgical residents, for young neurosurgeons. But unfortunately, in this part of the world, anatomy is not being respected. Same thing here. Here we have opened the posterior wall of the maxillary sinus, and you can see the pterygopalatine fossa. Go further down, then you will get the vomer and attachment of the base of the sphenoid bone. You have finished the orbit, you are seeing temporal bones, and then you are getting into the infratemporal fossa with the medial and lateral pterygoid muscles and the pterygopalatine ganglion and fossa. Go deeper, and then you will go into the nasopharynx here. And then you start here seeing the tip of the station tube as in here. How many of our neurosurgical residents, even of the young neurosurgeons, even of some of the old neurosurgeons know this kind of anatomy? The relationship of the orbit and the maxilla and the ethmoid is very important. Infraorbital nerve is very important to remember. The nasal septum made of bone and cartilage in front, bone in the backwards. And if you look to the lateral wall of the nasal cavity, you can see the inferior turbinate, middle and superior turbinates. Surgery was done here in this particular patient by myself and my colleague, Dr. Mohammed Sartawi, who's a facial maxillary surgeon. We've been working together for the last 30 years. He knows what I want. I know what he wants. So he would use the modified Weber-Ferguson incision like this, so that I can get into the axis of the roof and the medial and the inferior wall of the orbit. So this is the osteotomy lines that he's gonna use. So this is the boy under anesthesia. This is incision, defined Weber-Ferguson. Then you deepen your incision, you come to the bone here, maxilla. Here you come to the, as I said, nasolacrimal sac and duct. Here is the cut in the maxilla. So you can see that you are aiming to reach to this area because this is where the tumor is. Maxillary sinus, mold sinus, roof of the orbit. So proceed. Then you will come, as I said, into the nasolacrimal duct and sac, which is, you can see here. So nasolacrimal sac, the duct, the infraorbital nerve is here. That shows you the bony cortical incisions. So once that is done, of course, this is the, once we finish, this is the closure of Dr. Sartao. But before that, of course, having had done this stage, I would come in and I would use the navigation also to help me. But I always keep telling the young generation that your navigation is your brain, but navigation system gives you this extra bonus of confidence that you are in the right place. You know where you are and you want something to confirm it. If your mind does not go with the navigation finding, ignore the navigation machine and follow your instincts and your anatomical knowledge. So at each step of the surgery, I use the navigation to tell myself, well, I am there. Yes, I am there, and so on. So we'll need to show you the surgery. We'll show you the video now. The video was made in 3D, and we've been doing this 3D for the last 10 years. It's good for teaching residents, and it is good for conferences. We will convert it for the sake of our viewers into the 2D. So here we are. This is, I'm working at under the roof of the orbit, under the bony roof of the orbit. And this is, you can see the bony part, what is left of the cartilage and so on. You can see the nasolacrimal sac and duct here. But this is a tumor. This is not a cyst. This is not a sac. It produces bleeding. You will face. Here I'm trying to dissect the tumor of the dura, which is making the roof of the orbit. The bone is gone. The bone is destroyed by the lesion. So I'm removing the lesion of the dura. So the limit, the thing that is standing between me and the intracranial cavity is the dura. And you can see, I'll show you little by little that we are seeing the dura. Here it is. So peeling the tumor of the dura. Dura is very resistant to this kind of tumors. So there was no real intracranial extension. This tumor just pushed, eroded the bone, and took the dura with it superiorly. That's why we seen it on the coronary views. So this is the dura, and I'm stripping the tumor of it. Loads and loads of the tumor. This cannot be treated by embolization because, as I've said, danger of damage to the ophthalmic artery, artery and causing blindness. And it is not good for an injection. It is only good for surgery. Just trying to give you the message that this is a vascular tumor and should be removed piecemeal. Here I'm entering into the cavity of this. I'm reaching to the sphenoid. This is the cavity of the sphenoid. White stuff here. Tumor was inside. Here I'm putting the navigation marker. I say, well, this is the anterior clinoid here, should be. And to me, yes, the answer is yes, you are right. You are on the undersurface of the anterior clinoid. You can see it here that the bone is destroyed, as we have seen on the preoperative images. It's the same dura stripping of the tumor from within. Here is the bleeding, and this bleeding is coming from the anterior ethmoidal artery. It's a profuse bleeding, and if you're not careful, it may slip back and cause major damage to the orbit. Here it is. So this is the dura now free of the tumor, or almost free. This sphenoid sinus here. So you can see at the end that the dura is free, and then we go into hemostasis and so on. So this is about surgery. What about post-operative management of this patient? I'm sorry again for my voice because of my fasting. The material we got, we sent it to our histopathologist, Dr. Osama Farshakh, an American board of American College of Pathology, and he reported back. This is the gross specimen. So this is a tumor. Please stop saying this is a cyst. It is not. It is not aneurysm. It is a tumor. And his final diagnosis was aneurysmal bone cyst with no malignancy. And these are his slides. As I said, showing these spaces for the blood with fibroblasts, osteoclasts, giant cells, and so on. This is the 3 years follow-up. You can see the orbit is totally free, the ethmoid is free. This is with contrast. I think we have done a good job there for this little boy. You can see the bony work that we have done. This is the boy, and this is the scar of the incision. Eye movements improved. Proptosis started to improve. No pyramidal signs. Facial appearance is very good. And you can see here the proptosis is gone. And this is later follow-up, growing as a young man, as he is. And this is the last picture we got from him just yesterday, some 3.5 years after surgery. The last case I'm going to present to you is this 32-year-old man from Iraq. He presented to us with neck pain and occipital headaches on the right side. His head turning was painful. And funny enough, he complained of tingling sensation on the right side of his stomach. These are the images, and you can see there is a lesion here, which is centered over the jugular foramen, destroying the petrous bone. As you can see the lesion here, the bony destruction, the occipital bony destruction, the petrous. Coronal view, you can see here. You can see the jugular foramen here. You can see that the fourth jugular foramen is between the petrous bone and the occipital bone. It is destroyed here. Angiogram, you can see the vertebral artery, but this is destruction here. Bone here is intact. There is no bone here. And the CT angio showed that we can see the left jugular vein, but we don't see it on the right. It means that the jugular bulb is closed or closing. And it is here. You can see that you don't see the vein at all. CT scan showing the destruction in the region of the jugular foramen. So I referred this case, I was thinking about it. It is really challenge surgery for. Is there any way that we can do anything for this young man? And I thought careful about it, and I sent him to my colleague, Dr. Farid Al-Adham, who is a neurointerventional radiologist. He's American board. He is situated here in Amman, Jordan, and he will talk to you about the management. Farid?
Hello all, and thank you, Dr. Ibrahim, for giving us the chance to present this case. This was a challenging case, as you saw the images, very nice gentleman, young guy who has severe headache, persistent symptoms increasing recently. So once Dr. Specht decided that to see what other options besides surgery, I evaluated the images, I talked to the patient, and we figured we have some options in this patient. In general, if you look at the minimally invasive treatments for aneurysmal bone cyst, as Dr. Specht alluded to before, there is the intralesional injections with multiple different things that you could inject. Other option is endovascular embolization, either definitive treatment or preoperative, which can be done either by particles or liquid embolization, which has effect on the efficacy. And the last thing I want to mention is the percutaneous ablation of the lesions, either by heat ablation, by radiofrequency ablation, or cryoablation. These modalities are very much established in the peripheral bones, as you aware, but the majority of ABC is in the axial skeleton. So these are very much well established. However, using these modalities in the skull base is definitely something that hasn't been done a lot before. And for this patient, as you could see, this is a very challenging location, destroying the occipital condyle along the jugular foramen and encroaching on a lot of sensitive structures in that region. As you saw, there was extensive enhancement in the area. Again, you could see how close the lesion to the affecting the jugular bulb, and likely, if not occluding it, it's definitely narrowing it significantly. So after knowing how extensive is this and how the location, this is a reminder how is the occipital condyle in relation to the lateral mass of C1. This is where bulk of the lesion is situated, near also to the hypoglossal canal. That's why the patient actually presented with cranial nerve 12 palsy. When we thought about percutaneous access, this is obviously a way, not a common site for percutaneously accessing a lesion. However, we figured there is a few safe access routes for this tumor. In addition to that, so we had a plan of treatment trying to see if we can avoid surgery in this patient. The plan included endovascular embolization, supplemented immediately with percutaneous radiofrequency ablation of the APC. We chose the radiofrequency ablation rather than the cryoablation in this lesion because cryoablation has, it can actually extend beyond the margins of the bone, and however, heat typically is harder to extend beyond the margins of the bone. So that would be a little bit safer in that location. This is obviously patient was consented extensively about this kind of unusual approach for this lesion in this location. And after obtaining a proper consent, we did a 6-vessel cerebral angiogram. I will show you the pertinent images. This is a right external carotid angiogram. From the anatomy of the lesion, you expect that the ascending pharyngeal artery is a major supply to that region. So as you could see, the ascending pharyngeal artery is this small branch right here. And in this non-selective injection, you barely see a hint of the vascularity of the tumor. And that's just to show you, in these tumors, you have to be very selective. This is a selective injection. This is a microcatheter into the ascending pharyngeal artery. And immediately you see the hypervascularity of the lesion. Again, this is the lesion in the skull base with the hypervascularity. This was embolized with glue at that location. This is post-embolization with complete cessation of blood supply to that region. The other site that will supply to this supply blood to this tumor is the vertebral artery, small branches from V3 segments, and this was selectively catheterized. You see, this is a microcatheter going into these branches, and the angiogram showing hypervascularity, kind of cystic spaces that fills with blood within this tumor. This was embolized successfully. As you could see here, this is actually was done with onyx, both liquid embolic agents with different characteristics, but higher effectivity for actually penetrating the tumor than particles. So at the same setting to give the patient the best chance of cure, we performed the percutaneous access from a lateral, posterolateral approach to the tumor. Percutaneous biopsy was performed. This showed septations with blood cavities with no malignancy or giant cell formations. And then we completed therapy by percutaneous radiofrequency ablation of the tumor using a 2-centimeter Levine needle. This is just an illustrative picture of the patient. During the procedure, this was done while you see this is the radiofrequency ablation needle with the tines of the needle along the tumor. This one, the patient had 3 burns within the tumor. These radiodense spots are actually the embolic material deposited within the margins of the tumor. Again, you see here the radiofrequency needle within the tumor, and the high density material is the embolic agents. This is CT immediately after embolization, documenting that all the walls of the tumor is actually embolized with this high density material, killing the margins of the tumor or the wall of the tumor, which is a very important concept. 2 months after the procedure, this is a recent procedure. We just did it 2 months ago. This is the first follow-up, and you could see this is before the intervention. This is the margins of the tumor, as you could see. And just 2 months, which is relatively a short follow-up, there's dramatic decrease in the size of the tumor. And the radiodensity here is actually the material deposited in addition to early calcification and ossification within the tumor. Dramatic decrease in size. Again, this is the tumor post-embolization with actually almost formation of the regular bone margins. Almost done here with tumor before embolization, after embolization. Dramatic decrease, early follow-up. This is just 2 months. The sagittal view, pre-embolization, both. This is what's visual there. We're all done here, showing that this is definitely a way to handle these kind of tumors in such patients. Patient had mild cranial nerve palsy 9 that improved within 2 months, and his all other symptoms resolved completely. He will have follow-up in 6 months. Thank you.
Okay, so we're finished, and myself and Dr. Farid Al-Adham are ready to take your comments and questions if there is any.
Very good, Dr. Sabaya. Thank you very much. Okay, the floor is open for comments or questions. Go ahead. We have one in the chat box, Dr. Sabaya. So ABC is rare. That USA paper showing 60 to 100 cases, was that a large institute?
Sorry, I did not hear that, John.
Okay, that USA paper showing 60 to 100 cases, where was that from? What was that from, a large institute?
Nothing was done in the skull, in the skull or the skull base. It was all in the long bones.
Okay, okay, very good. Okay, more comments, questions from the panelists. You can either write them or just step up and use this interactive platform. Hopefully you'll take advantage of this interactive forum, especially to me. Go ahead, Mohammed. Go ahead, Mahmoud. I'm sorry. Go ahead.
Hi, my name is Mahmoud. I'm one of the students of Professor Sabah. First, thank you very much for this very nice presentation. I have a question about the last case. You see, that case actually, the percutaneous axis, I think, was very tricky because it's in the jugular frame and it's very close to the like 9th, 10th, and 11th nerves. And so my question is, how do you access this lesion? I mean, what trajectory did you use so that, you know, you can make sure you don't actually hit the nerves with the needle? I mean, I know you can't control what happens regarding the radio frequency, but I mean the anatomic axis without like injuring the jugular or the cranial nerve should be very tricky. So any points on that?
Thank you, Mahmoud. And I have to point out that Mahmoud was one of our residents. He finished his training and he's having further training in UK. Thank you, Mahmoud, for your question. And I refer the question to Dr. Farid Al-Adna.
Thank you, Mahmoud, for the question, and great to hear from you. You are right. This is definitely a very tricky site to percutaneously access. So the answer to that, this was very much planned based on multiple, the CTs, the MR, and then this was done by what we call DynaCT guidance. Essentially, this was done as under direct imaging, fluoroscopy, and taking that fluoroscopy, converting it to a CT at the same time. You could advance the needle from a safe projection that we decided pre-operative into the lesion, knowing that the inner margins that we don't want to extend to, so the burn was controlled in the center of the tumor, and that was purposely done knowing that we treated all the periphery of the tumor with the embolic material that was deposited, as you saw. So the bulk of the ablation was done within the center of the tumor, leaving a small margin along the periphery, not extending the needle or the heat to that level, so we be on the same side. The patient did develop mild cranial nerve 9 palsy that resolved after a couple of months, but that was expected, not from the heating actually effect, that was from the ascending pharyngeal artery embolization. It is a well-known dangerous artery, and we expected that, and we discussed about it. And as we've seen before, these are typically reversible. So very tricky, yes, but augmented with the other modalities, that was relatively safe, and the patient did well with that.
Thank you, Farid. Thank you very much for your question. Any other comments or questions?
Okay, more comments, questions? Step up. Now's your chance. At least to meet Dr. Sabaya. Sunil, are you there? Sunil, I know some names here. I'm going to be a pain.
I think there's a question in the chat.
Okay. Okay, yeah, go ahead. Do you wait for the formal biopsy result before proceeding to RFA?
Again, I refer the question to Dr. Farid Al-Adna.
We actually did not wait for the biopsy for main reason. One, the imaging was very characteristics of ABC. This was done essentially to try to figure if this is a secondary ABC to an underlying giant cell tumor, and this was proven not to be the case. That would not have altered our treatment plan by doing the radiofrequency ablation for this tumor.
Okay, thank you. Omar Atala asks, in case of recurrence, can we repeat the non-invasive intervention, or we should go to the surgical option? And what are the challenges if we choose to go to surgery?
If we need to go to surgery again, already for the surgery for the first time, this is something like the glomus jugulare. You are operating on the jugular foramen, jugular bulb area. It's a very, very tricky surgery, and it should be only done in the most experienced hands. So surgery for the first time is difficult. So you can imagine how much difficult it is when the thing occurs. So any chance to get away from surgery in that particular area, you have to use it. So in case of recurrence, you would like to repeat what you have done in terms of embolization again. And if that fails, then you have to go into this very tricky and dangerous surgery. Farid, do you want to add anything?
I agree that as treatment of recurrence, typically injecting the lesion actually more than once percutaneously is almost the norm in these lesions. Rarely they do respond by one injection or one treatment. Our case was particular or different because we augmented the embolization with radiofrequency ablation, hopefully to prevent that. But can we access this again and install any of the percutaneous intralesional therapies? Yes, we can do that.
Okay, very good. More comments, questions? Sunil, do you have any comments or questions? Or Roberto from Italy? And let me see. Go ahead, Sunil.
Hello.
Go ahead, Sunil, go ahead.
Actually, good evening, sir. Actually, I don't have any questions, but just like I like to introduce. I'm from China, and like in China, like I'm doing residency here. So my name is Sunil Ronia.
See, that's the beauty of this platform. You can meet someone like Dr. Sabea online. You're in China, he's in Jordan. You know,
Yeah,
so this is a beauty. This is great. This is great. Okay, there are more people that would like to at least introduce themselves. Take this opportunity to meet these fine gentlemen. Okay, I guess people are a little shy today, Dr. Spade. Okay, great. Thank you very much for this presentation. And I guess we'll expect to see you Wednesday, correct?
Wednesday, the same time.
Okay,
And we'll present the petroclival meningioma personal experience.
okay, very good. Thank you very much. And thank you all
Thank you.
panelists for coming.
Thank
We'll
you.
see you. Bye-bye.
See you. Bye-bye.
Okay.